I'm really happy to be here with all of you tonight. And thank you for coming. This is a really wonderful event. And the interesting thing that we're going to talk about tonight has to do partly with the problem of pain, but more specifically with the problem of pain killers. And I call it from harm to pharma and back again to harm because, believe it or not, the way our bodies process pain and the way we have learned to treat pain are part of an overall picture of how we've arrived at the place where we are today with the opiate crisis. So I want to take us back a little bit and talk about how we got here in the first place. So this is a lovely image. By the way, this is dentistry. So I'm from the Dittrich Medical History Center and Museum. Anybody been down there before? Hey guys, how you doing? We have 175,000 artifacts from the medical past. And the Dittrich Museum is a really, really fabulous place. I'm research associate there, and my name is Brandy Schillace, and I work with the chief curator there as well. One of the things that we have a lot of are our tools from the past that make you really happy. You don't live in the past. We have a dental exhibit right now, a special dental exhibit that'll be up through December. And this is what you were asking for if you needed to have a tooth pulled back in the day. We have a device called a tooth key. It looks like an old roller skate key, kind of. So you set it in there, and it had a little hook, and you put the hook on one side of the offending tooth, and you gave it a quick twist. And that's because speed was kind of important because of the problem of pain. So I call it the grim surgery. We have lots and lots of surgical equipment at the Dittrich Medical History Center and Museum. And you'll notice a few things about these devices, right? One, they have wooden handles. Is that a problem? It is a problem, yes. You can't sterilize that, and lots of little places for germs to hide. That picture to one side there, he's actually sawing off someone's leg. And this happened quite frequently, and it happened frequently because if you were walking through the fields and you stepped on a nail, today, after taking the nail out, you'd probably treat it with some sort of disinfectant. You might go to the doctor and have him look at it. But in the 18th century, if you stepped on a nail, you were probably in a lot of trouble. If it got infected, you could get gangrene. If it got gangrene, they were going to amputate it. But amputation was a curative for all sorts of things, like compound fractures. They didn't actually know how to set a compound fracture. So a lot of times they would just amputate your leg because they figured that it would become infected and you would die. You can see here the gentleman does not look particularly pleased with this arrangement. This actually comes from, Fanny Burney was an author. She wrote Evelina, a number of other books, but she also, in the 18th century, had breast cancer. And most of us probably assumed that if you got breast cancer in the 18th century, that was it for you, but not true. They actually did operate. And here's a description. And again, I know this is a bit gruesome, but I think that in this case, a picture was not worth 1,000 words. I decided we'd go with words. Yet, when the dreadful steel was plunged into the breast, cutting through veins, arteries, flesh, nerves, I began a scream that lasted unintermittently during the whole time of the incision. When the wound was made and the instrument withdrawn, the pain seemed undiminished, for the air that suddenly rushed into those delicate parts felt like a mass of minute but sharp and forked poignards that were tearing the edge of the wound. But when again I felt the instrument describing a curve, cutting against the grain, if I may so say, while the flesh resisted in a manner so forcible as to oppose and tire the hand of the operator, who was forced to change from right to left, and then indeed I thought I must have expired. She's writing this to her sister after the surgery, and she talks about how she could hear it, she could feel it. She was awake during this surgery. You would have been awake during an amputation as well. There were two things we lacked in the early days. One was any kind of antiseptic, which is a problem because a lot of people died after even a successful surgery because of the post-operative infection. They didn't know what caused infection. They actually thought pus was good. They called it laudable pus. Like, oh good, it's working. The second thing they didn't have was anesthesia or any other real means of killing pain. You were awake during your surgeries. Now, the interesting thing about that, though, is that that was considered a good thing. It was considered a good thing. Pain, we don't like pain, right? Nobody here likes pain. If you have a headache, what are you going to do? You're going to take an aspirin, right? You're going to take an ibuprofen. We don't deal well with pain. We don't like it. But there was a time when pain was such an everyday part of life. There weren't painkillers. You just sort of got used to it, that they thought pain had purposes. As a matter of fact, they had some really funny, superstitious ideas. They thought, for instance, that if a woman didn't experience pain in childbirth, she wouldn't love her child. I'm pretty sure a gentleman came up with that one. But they did. They thought pain was good. If you were screaming during the surgery, you hadn't died. It was a good indication that you were still alive and that you might make it. Robert Liston is a really interesting figure in history, and I like to talk about him in part because of this time issue. If something hurts, time stretches. So for surgeries, they were really interested in doing this quickly. Robert Liston was known as the fastest knife in West End. He could remove a leg in 2 minutes or less, and he used to start every surgery by shouting, "Time me, gentlemen," which I don't know about you, but I don't think that would have instilled in me a lot of confidence in my surgeon. They worked at speed, and they were actually quite effective. Most of the time, people get upset when they see the bone saw. We have lots of those on display, and people shudder at the bone saw. But it was over by the time you got to the bone saw. In order to remove a limb, it's a little bit like disjointing a chicken. I'm sorry for the analogy, but you cut around the tissue first with a sharp knife. And only when you got to the part that you couldn't actually remove anymore, that's when you use the bone saw. They're moving at speed. That's a lot of flesh and tissue that you're trying to remove from someone who's awake and not holding still. And there's a lot of other people involved. I mean, someone's holding the leg, someone's holding down the arms, they have you strapped to the chair. Robert Liston once cut off 2 fingers of his assistant in the middle of a surgery. That's how fast they were moving. The patient in that particular surgery died, and the assistant died of infection. So a 200% mortality rate for a single surgery. It's not particularly good odds. But of course, they expected that you wouldn't live through surgeries. They did. They also expected that you would just deal with the pain. Some of the first discoveries are actually much, much earlier than the modern these surgeries of the 18th century. Herbal remedies have been around for a long time, and headache powders, sometimes rather alarming tinctures. They used very strange things in medicine. I remember there was a curative that involved pigeon poop. I forget. Crushed up pearls and pigeon poop was one. I doubt that worked. I don't recommend that one. But also alcohol, obviously. Alcohol was something that they did use, but believe it or not, they didn't use the alcohol so much as a painkiller as to sort of bolster the nerves. This idea that you were going to be ready. They were kind of steeling you against the pain. It's not till you get to opium poppy resin that you really start to see opiates from the opium being used. And the interesting thing is, for a long, long time, it's not actually a terribly effective drug. And here's why. Opium poppy resin, the sap from the opium poppy, is unpredictable. And they didn't really understand what part of the plant was actually doing the job. So, for instance, you're using the whole plant to try and make this compound. They thought that the bitter, acidic part of the plant was the business end. And in fact, the bitter, acidic part of the plant is frequently nothing to do with its actual properties. It's the alkaloids. It's the non-acid part of the plant. But they didn't know that. So you were getting a mixture that may have, it's very difficult to tell exactly what percentage of the alkaloid, the actual the opiate compound you were getting in a tincture, and they dissolved it in alcohol. Laudanum is used lots in the 19th century. How many of you probably heard that word before, laudanum? They gave it to babies when they were fussy. I imagine it worked. But it's also, of course, again, you don't know how much you're really taking. If you go and you pick up some laudanum from your druggist, and then you move to a new city and you go to a druggist and you ask for laudanum, there's no guarantee that those amounts are actually going to be the same. There's no guarantee because they're making each one of these batches from big blocks of resin that they're sort of like dissolving in alcohol. It actually isn't until 1815, and that's late. We're talking about, it's the 19th century at this point, 1815, when the first real breakthrough happens. And it's pretty astonishing how it comes about. Frederick Surgenor, he's the one we have to thank for morphine. He does something a little strange, and some people have said it's almost a bigger breakthrough, more influential in medicine even than penicillin. And here's why. He was the first one to say, you know, it's very expensive starting with the raw compound. The poppies themselves, the resin, we're importing it from far away. It's very, very difficult to know what we're dealing with. There's got to be some active principle in there that's doing this work. And strangely enough, that concept actually comes from alchemy. Way back in alchemy, they always thought everything had some sort of active principle in it. So he begins wondering what in this big sticky block is actually doing the job. He tries separating the acids, he tries separating other bits, and basically he keeps ending up after each test with this sludgy stuff in the bottom of the vial, which he throws out. And then one day he thinks, you know, what if it's in the sludgy stuff? So he starts with this cloudy precipitate, and he starts messing with it. He finally managed to extract some little white crystals. And as they did in those days, he fed it to a dog. And the dog got tired and fell over and died. And he was thrilled. He was super excited about this. I know, I'd be sad myself, but he was like, oh my gosh, we've discovered it's actually in this other bit. It's the non-acid part of the plant, the alkaloid part of the plant. He spends weeks, months, and years finally getting this little fine powder. He's very excited about it. He publishes a paper, and he waits. He's like, all right, I'm ready. And nothing happens. Like, nobody cares about this. And some of it is because he wasn't very well known at the time. He was young, and he's doing this in back rooms in his spare time, and it doesn't look like real science to any of the people he's working with, and laudanum works fine anyway, so why are we bothering? So for a while, he just hangs out, not really being able to convince people. Then he decides that the way to fix that is with a test subject, and he does something very, very stupid. In history, a lot of doctors were also self-experimenters. One of my favorite stories is cocaine eye drops, cocaine to numb the eye. The man who discovers this pokes himself in the eye with a pin to test it. Don't do that. Surgenor actually practices on himself and all of his assistants. And this is one of those times when, like, probably you should pick someone to be the designated driver in these situations. So he mixes the white powder with some water, actually I think it was alcohol, and administers it to himself and both of his, or actually there were three of them, all three of his assistants, and promptly they all have massive overdoses. And Surgenor manages to climb to this vial of vinegar, which he drinks as an emetic, and it causes him to throw up. So he throws up the drug. He comes over and he's pouring vinegar down the throats of these semi-conscious people. They all vomiting everywhere. And he's like, a success, we were successful. So it's not a clean kind of experiment at all. And he almost kills himself and 3 other people. But he realizes he's isolated the actual drug, and he publishes this paper. This time, it actually catches on. He's overjoyed, that's how he describes it, overjoyed. I'm thinking of this vomit-filled room, and I'm going, that's an interesting, okay. But he's really pleased with what he's done here. Surgenor publishes a paper that gets picked up by a Frenchman who is much more important than he is, Guy Lassac, and he translates it, and it goes everywhere, and all of a sudden everyone knows about this, and they usher in an era of alkaloids. they are very excited by this prospect because it means that you can perform surgery, potentially, and other things where you can actually kill people's pain. But it doesn't get used for that, not for a long, long time. What it does instead is it ushers in an era that I think in some ways we are still experiencing today. Once people realized that the bits of the plant they'd been throwing out were actually where the compound really resided, it meant a whole new window opened up for experimentation. And they went looking for all the alkaloids they could find. They also decided to give it in their Latinate name, I-N-E, "ine" at the end of the word. So originally they called it morphium, becomes morphine. Other "ines" like caffeine, nicotine are all alkaloids, and these are things that we experimented with and were able to isolate, and that meant you could actually administer them in doses. And it also led to more rash behavior. When we feel pain, it's a chemical signal, actually, to your brain. So if you're playing with chemicals to block those signals, you're interfering with communication that's happening in the body. Remember, there was a time when everybody thought pain was actually good and a part of life, and you should experience it, and it was how you learned about things. Now, all of a sudden, we have a wholly different idea of what we can do to block various pain pathways. And it's really, really complex. There's all different ways that we feel pain in different places to block it. Alcohol, for instance, dulls the sensory up here. It dulls your sense up here that you're being in pain. It doesn't actually stop the pain at the site. Something like aspirin, the reason that dissolving an aspirin in your toothache works is because it can actually work at the site to block the signals being sent. So there's different ways that you can deal with pain, and certain drugs change the way the brain receives messages. But that's ultimately where we run into trouble. Because when you change the way the brain receives messages, you're also inviting things like addiction. Caffeine, nicotine, quinine, codeine, all these alkaloids, they're hugely successful. And the search was on for a new mean of killing the pain and seeing how we could ultimately use it. Cocoa, that was exciting. Cocoa leaves. If you chew cocoa leaves, which is done in other cultures, it has like a property in it that's like cocaine. But remember, we're now isolating all that stuff. Remember before I said you're dealing with the whole plant. You're mixing, you don't know how much of the acid and alkaloid you're getting. But we're learning to isolate these things, which means we're getting a much higher and more refined dose. And we're learning there's all kinds of ways that you can use it, like Coca-Cola, Coca wine, Coca soothing drops and lozenges for children. So a lot of these are actual advertisements that were created to sell Coca products to people, and particularly to sell it to children. They call it marvelous restorative Coca wine. You just feel so refreshed afterwards, and people kept coming back for obvious reasons. The magical drug. Now, the one that I'm going to talk about ultimately in this process is heroin. But let's not just leap there. But I do think it's important to understand that it was considered magical. These drugs were considered answers to prayers. They were considered almost like magic wands. Sigmund Freud is very, 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 very fond of cocaine. Exhilaration and lasting euphoria, which in no way differs from the normal euphoria of a healthy person, says Sigmund Freud. You perceive an increase of self-control and possess more vitality and capacity for work. You are simply normal, and it is soon hard to believe you are under the influence of any drug at all. Long, intensive physical work is performed without any fatigue. This result is enjoyed without any after effects that follow exhilarations brought about by alcohol. No craving for the further use of cocaine appears after the first use, even after repeated taking of the drug. Sigmund Freud ultimately becomes an adamant addicted cocaine user. So it's very interesting. They did not think that these were dangerous. They really thought that they had found kind of a magic bullet. But let's go back to the surgery. We're making fun here of ether in this particular drawing, but let's go back a little bit further to laughing gas. Humphrey Davy. I'm a big fan of Humphrey Davy. Is anybody familiar with who he is? So I wrote a book called Clockwork Futures, and he's one of those inventors that he wanted to make a name for himself. And he always wanted to. He was very young and eager to kind of make his mark. And he began experimenting with gases. And the interesting thing about these gases is the use he ultimately put them to. He realized that by inhaling laughing gas, it dulled the senses, things became, they called it laughing gas because it's just, everything just seems so funny. You don't always laugh, but they often do. You just feel so good and happy. He was a scientist. He was looking to make his mark on science. He used the laughing gas for parties. He doesn't actually do anything scientific with the laughing gas at all, even though he works with doctors and other scientists, but he found out it was fantastic at parties. So laughing gas parties become all the rage, and he gets into a bit of trouble with his boss's wife, actually, as a result of that. But these laughing gas parties, they're inviting people in, and they're saying, try this out, and it's almost like, the euphoria lasts, people sitting in corners and giggling, and lots of times there's people there like taking notes on what's happening. But one person who was invited to this party was a man named Wells. Wells was a dentist. So back to that horrible image of the tooth pulling, and imagine trying to get someone's wisdom tooth out when they can feel the pain. I had my wisdom teeth out, I was awake. I couldn't feel the pain, but I was awake, and that was bad enough. Someone's got their knee on the chair, and that's not a good thing. Wells realized that gases might be the solution to complicated dental surgeries. By the way, people's teeth were not in particularly good shape in the 19th or early 20th century. One of the things to blame was the better availability of sugar, cane sugar. That meant that the more money you had, the higher your status, the more sugar you were able to get, the worse your teeth tended to be. In the 18th century, it was not uncommon for well-to-do people to pay poor people for their teeth. You'd yank out a healthy person's teeth and you'd stick it in the hole of your own. Apparently, it would stay in there for a month or so. So I don't know how many poor people's teeth you'd have to go through. If it was just for special occasions that you put a tooth in there, I'm not quite sure. But essentially, if you were poor and you had a diet that didn't consist of much sugar, usually your teeth were better. But on the whole, dental hygiene was not fantastic. So Wells worked with patients a lot, and they'd already begun experimenting with other types of anesthesia, other kinds of painkillers, but he had not used anything as a dentist, and he thought laughing gas is the way. He called his friend Morton and said, I think that the two of us can really do something here. Let's go to Harvard Medical School. Let's see if we can impress them with this new method of extracting teeth. So they brought, laughing gas was in a bag. It's almost like the way you do helium. You've done helium, right? You've done helium, right? Anyway, so he had laughing gas in a bag. I'm going to ask you guys to edit that out. That's going to be ridiculous. But and they give it to a male student who had trouble with his teeth who was in the audience. And at that point, Wells comes forward to try and remove his tooth. No one's exactly certain what happened next, but the student made a noise. It was interpreted by those present as a cry of pain. And they started hissing and throwing things and yelling humbug. Humbug was a very naughty term to say to doctors. It basically said, you're full of it. And they just laughed them out of the enclosure, out of the surgery. And Morton and Wells are mortified. And Wells ultimately commits suicide after this event. But Morton felt like there's something to this. And he saw the money-making potential. So Morton decides to practice with something else. Vitriol. Sweet oil of vitriol, or vitriolic acid, also creates a vapor. And the vapor that comes off of sweet oil of vitriol is ether. He begins doing experiments with ether. And the first person he tries it on, not surprisingly, is himself. So sitting in his study, he puts ether on a cloth. He's basically douses things down, and he puts it over his own mouth, and he passes out. But the scarier thing is he wakes up, but can't move. It's temporarily suspended all of his, he's awake, but he can't actually do anything about it. And he becomes terrified that he's going to die in this state and be a laughingstock. I think it's interesting that he's more worried about being a laughingstock than about the fact that he might have just killed himself. But ultimately, he takes the ether and he's decided to go back to Harvard. And this becomes a turning point in history. They allow him to come try again, mostly because some of them want to see him fall on his rear end again. He goes to the Massachusetts General Hospital and he comes in with the ether in a new device for inhaling it, and a man with a tumor in his neck is about to be operated on in the theater. And if you've never seen we have photographs of this at the Dittrich, and you can come see them. But surgeries were like, it's like all of you in here, and I'd just be operating on someone right here. You're just watching, just random people from the street are watching, doctors are watching. There were times when they would even sell tickets to things like this. It's kind of strange. So there's a bunch of people watching, and a man's about to have a big tumor taken out of his neck. And Morton says, okay, we're gonna do it my way. He gives him the inhaler. When the man starts to feel groggy, he tells the surgeon, your patient is ready. He begins cutting, and the man remains perfectly still and makes no sound. They finish a long and complicated operation, and the patient said he felt only a scratch, and it was considered a massive success. The surgeon turned to the audience and said, this is no humbug. He then, another surgeon actually calls Morton shortly after and says, you need to give this a name because people are going to ask for it. I suggest anesthesia. So it began to be known as anesthetic ether. And on one hand, this should be the end of a successful story, right? We should go, yay, well, we did that now, and we can have surgeries, and it'll be a wonderful thing. But it was also an incredibly lucrative discovery. Morton and others who were experimenting with these pain-killing and these anesthetics were making a lot of money. It's also the Industrial Revolution, and we have something else lying around. It's called coal tar. It's the waste products from oil and gas, or coal and gas. And some enterprising companies decide that what we really ought to do is make money from our pollution by turning it into drugs. And this is where the story gets really sad. And also, in my opinion, how we have inherited a lot of the issues that we're having today come from this. Coal tar, plenty of it around. Bayer is a dye company. They make dyes. And they had discovered that you don't have to start with an opium poppy. You don't actually have to start with the plant. They realized it was just chemistry is really taking off. They're realizing it's compounds of carbon, it's all these atoms, and we can get carbon from anything, like this coal tar. They start bringing the sludge into the laboratories and mixing it and degrading it and trying to pull out different carbon atoms and other things from it and to create new compounds. Some of the compounds they make, salicylic acid, they start going from the natural to the synthetic. And they make at Bayer, they make two big discoveries. One of them is aspirin, and the other one is heroin. When we talk about the opiate crisis, we talk about opioids, we often think we're talking about opium, a plant, but we're not. Many of the drugs that we have problems with today were man-made, created from our own pollution, to sell to the public. It got its name, heroin, because the head of the laboratory thought it was a very heroic drug. And if you gave it a name that sounded like heroism, people would want to take it. They made lots of money from heroin. They did not sell aspirin. After they made aspirin, they decided it was much too dangerous to use. It was probably bad for your heart. Oops. Cheapest, specific for the relief of coughs. Later, they did come back to doing aspirin, and I noticed that they actually put a little notification at the bottom of their thing saying, but it's okay, it's okay for your heart, we tested, it's fine. They sell heroin for years. And it doesn't take very long for people to start seeing some pretty unfortunate effects. The heroic drug, not that different from the way Freud describes cocaine as being, it's euphoric and it's great and I'm stronger and better and smarter and it's awesome. Heroin had much graver side effects. And the side effects came a lot faster. and the high did not last as long. That is, your body became unable to reach the high, and it took more of the drug. They realized that it was dangerous, but a little late. People realized heroin wasn't actually that hard to make, and it was very inexpensive to produce for companies. We have safe surgery, but we've ended up with all of these other compounds: barbiturates, blockers, inhibitors, chloral hydrates, ether. These things were quite dangerous. Chemists were building pharmaceuticals one molecule at a time, and there's no way to test this. You'll notice that the age of self-testing kind of goes by the wayside in these mass productions, and you don't have doctors knocking themselves out with their drugs. You do have drug trials, and not very many of them. The drug trial for heroin was the guy who made it went, "This seems pretty good. Let's see if we can sell it." Chronic pain and magic bullets is where I like to go next, because I think this is a really complicated topic, isn't it? Opiates can be good, or they can be really, really bad. I'm a migraine sufferer, so I'm glad that we have painkillers. But we also have problems of epidemic proportions, and not just in Cleveland, Ohio, and Lakewood, but all over the country. And I think it's important to remember that so much of the rhetoric tries to focus on users. And I think history is really important, because doctors prescribed these drugs, companies manufactured these drugs, and they did it for only one reason, really. There were other means of killing pain at that point. They did it because it sold, and because when you have an addictive substance, you have no trouble selling more. The first drug dealers in the United States were companies. And that is something I think is worth bearing in mind. At the same time, we have to remember that opiates are also a last resort for some people. Pain is a terrible thing to live with. I have chronic pain because, as a migraine sufferer, I have a kind of migraine that, in fact, isn't so episodic. I basically have months where I'm dealing with them. So it becomes a very chronic issue, and it's very, very hard to function. Now, you take that and you think of someone who's suffering from fibromyalgia, or who has a terrible disease or a wound or some other kind of non-healing ailment. And if you're living with chronic pain every day, and it's hard to get out of bed, and this one thing makes it better, I think we can all understand what it would be like to be in that situation. So I end by saying pain management isn't a bad thing. Where we've ended up today is a lot having to do with miscommunication, having to do with mismanagement, having to do with social problems that have nothing to do with the drugs themselves. But I do think that we are trying to move forward in the treatment and management of pain. At the same time, we're trying not to have epidemics of drug abuse. And you can't just decide, okay, no more painkillers. You can't do that. You can't just decide to make every kind of blocker unavailable to people. How do we manage these very complex problems? And how do we keep in our minds this weird history of how we got here in the first place? And our changing understanding also of what pain is. Going from something that we thought was that you just live with to a time period where we don't want any pain. And is there some kind of middle ground? How do we arrive where we are today and where we go in the future is often really rooted in our history. And the District Medical History Museum, and many thanks also to Lakewood City, is a place where we try to explore those stories. Because the ethics of the problems we have it's never one-sided. And I tell everyone I give a lot of tours at the museum, and I tell everyone who comes, medicine is neither good nor bad. Technology is neither good nor, it's amoral. It has no moral grounding. It's how you use it, and who uses it, and who has access to it, and why. And for me, that's really the story of all of our medical challenges and many of our social challenges as well. So I want to stop there and bring up our panelists. We're going to have a short panel discussion, which we are then basically with introducing what they do and their thoughts. And then we're going to open it to the room, and I welcome your questions, your comments, your commentary. One of the best things about the Conversation series is that they're conversations. So we love that, and we love to hear your voice. So let me welcome our panelists up to our table here. I'm actually going to moderate, so I'm going to sit right here. Thank you. So you guys will have to share. What I'd like to start off doing is actually allowing them to introduce themselves. And so they're going to tell you a little bit about who they are and what they do. And I'm going to ask them a few questions about where we are today, just to warm us up a little bit. And then I welcome you to join in the conversation.
My name is Katie Kurtz. I'm the clinical manager of the Department of Human Services for the City of Lakewood, and I'm helping take a lead on Project SOAR, which is a new pilot program happening here in the city.
My name is Gina, Mineo, and I'm a person in long-term recovery. I'm employed by the Woodrow Project, which is recovery housing for women. I'm a state-certified peer supporter and a state-certified chemical dependency counselor's assistant. I will be the peer support coordinator for Project SOAR.
Hi, everybody. I'm Judy Welsh. I'm a board-certified emergency physician and the Lakewood Emergency Department medical director. I have a personal interest in helping with the opiate epidemic because we see patients every single day who suffer from the consequences of opiate use, and we want to do what we can to help them out.
All right, thank you. So were any of you surprised by this back history? I know some of you actually probably know it, but were you surprised to discover that a lot of our problems are actually man-made creations based out of economic viability?
I don't find that surprising in the least. I remember, almost 20 years ago when I was a medical student and a junior resident, and we were taken out to dinner by the drug companies, and, we didn't have anything. I was poor as a, church mouse, and they would buy us, really flashy dinners, pick us up in the limousine, take us to the Bills games because I trained in Buffalo. And it's not surprising at all that this is exactly what the background is.
I know the moral, I guess, surprise isn't too much of a surprise, but the fact that heroin doesn't come from opium at all, that is a surprise to me.
It tends to be a surprise for a lot of people because we think of, well, they're called opiates. We tend to assume that they come from plants. But almost all of our chemical compounds started off as plants, and we've engineered them over time because it is cheaper and easier to do so than actually farming the plants themselves. So,
I was also surprised by that when I first met you, and you told me that story, and I've since shared that because when we think of what, when we look, I always think of our county medical examiner who reports out on overdoses and deaths to overdoses in our county each month. We're starting to see a plateau of deaths and overdoses from heroin, and we're seeing a rise in overdoses and deaths to overdoses from synthetic, so fentanyl and carfentanil, and those are all, again, manufactured.
Mm-hmm. It's a really interesting topic, and what I'd like to ask you as a panel to respond to, and what I hope the rest of you will talk about too, is, we have a tendency to see these issues as black and white, as like, drugs bad, don't do them. But it's a much more complicated issue. These are actually, many of these are helpful drugs, or at least started off that way. How do we address that when it's not a black and white issue?
Well, I think we have to see them for what they are, and we have to engage the patient for us as physicians in the conversation and say, listen, there's a risk and a benefit to everything that we do. Mm-hmm. You have a painful condition, you broke your arm. We have lots of different treatment options. Some of them are non-narcotic. I'm going to splint your arm. I'm going to send you to an orthopedic surgeon. Maybe you'll qualify for surgery. We have Motrin or Tylenol as an alternative, but there are going to be times when your arm really hurts. Maybe it keeps you up at night. Maybe you can't function. And opiates are an appropriate treatment for that condition in time-limited quantities. But if you have a patient who has a history of addiction or a family history of addiction that could put them at risk of misusing this medication, you have to have an honest conversation and say, listen, this is the risk. Is it a risk that you accept? And let the patient make the decision and make them aware of what they potentially could be getting themselves into.
I guess from here, I'll speak personal experience. I was prescribed opiate painkillers. I had a jaw surgery, and I wasn't informed of the risks at all. And addiction did run in my family, and I don't know that it would have been any different for me personally, but I think that, at least knowing would have given me some insight, even if I would have become addicted, as to what was going on. Because when I didn't have it, and I was physically ill, I thought I had the flu. I didn't even know the problem, so I certainly didn't know the solution. And so, yeah, just, giving people the knowledge to arm themselves with.
I think from a perspective of a social worker in human services, we're not usually ever there at the beginning. We're usually there far after. And so we're often seeing addiction as a disease and as the addiction, not of the specific drug, and trying to work with individuals and families and linking them to recovery so they can find the best solution and the best time for that solution themselves.
I think it's important to recognize, again, just to go back to the history, when they first developed these, let's talk about Humphrey Davy for a moment. Humphrey Davy just used it, he completely just used it recreationally. He never even tried to make this a medical thing. He was like, hey, we can have parties, guys, and that's what they did. And he's not the only one. Ether and chloroform to varying degrees were also used in those ways, but they tended to have worse side effects afterwards, which is why you didn't have so many. You didn't have chloroform parties like you had laughing gas parties. But that was a purely recreational use, and it was a very highbrow thing. It was like going to a cocktail party. And I want to talk for a minute about stigma, and I want to ask you about stigma because if someone says they're going to a cocktail party, we all are kind of like, oh, they're going to wear fancy dresses. But if someone says, well, I'm going to go smoke some weed, or I'm going to go, it's a totally different understanding of what that is. And can we talk about the stigma that's related to opiates that might not exist for cigarette smoking or alcohol?
Yeah, so stigma, I think, is the number one barrier to accessing recovery support and treatment. And when we think about addiction, especially the opiate crisis, really heavily hitting our county and our country, we're very quick to be reactive and create, because this problem has gotten so big, we can't catch up with it. We're sprinting behind it, trying to help and create accessible recovery supports for individuals. We're way far behind in prevention, and what I think is so important in all the work we do, and especially what we're doing within the city of Lakewood with Project SOAR, which is supporting opiate addiction recovery, is everything we're doing, even though we're responding quickly to people who are actively using, everything we do is to reduce stigma, because we want to create a culture shift. We want to break down the barriers to access the recovery supports that are available. Having these kinds of conversations is in and of itself breaking down stigma, because we're talking about it. We're not hiding away from it. And I think that's really important to note, and that all of you are taking part in breaking down that stigma, which is therein of breaking down the obstacles to getting into recovery.
I think I just touched on it a little bit, but if I was armed with the fact that I, had addiction in my family, maybe that would have put me a little bit more on guard, for anything, for alcohol, for, any kind of substance. But I didn't know, and it wasn't talked about because of the stigma. I don't think there was a definite time where my parents said, we're not going to talk about this because, people will think we're bad people. I just think that it was so ingrained, and it's going to take a long time to get those behaviors and that thought process out of our community and out of, many communities. But I think if at least I'll speak for me, if I continue to do what I'm doing and others like me continue to do what they're doing in breaking down the stigma, I think that, like Katie said, we'll still be sprinting behind it, but I think that we can, grasp a hold of it and work on it.
I think people do resist seeking treatment because they're afraid that we will judge them for a whole variety of conditions. It could be an STD, it could be, self-inflicted wounds, it could be anything really. And honestly, I think, as a healthcare provider, I think the best thing I can tell people is I don't care. I don't care what you're there for. I don't care if you're straight, if you're gay, if you're white, if you're black, if you're pink with purple spots. I just want to take care of you. That's what I get paid to do. And so as healthcare providers, we need to learn more about addiction. We need to learn more about caring for people who have substance misuse problems. But really, we're not judging you. We just want to take care of you and do the best that we can, even if we don't know everything there is to know.
I want to say two related issues, and this is something also that we're working on a lot at the District Museum. These issues of stigma and of drug abuse, of the opiate crisis that we're facing are really not, you can't separate them from the fact that we have poverty and problems of access. I mean, problems of access apart from the stigma, just people getting access to healthcare and having proper insurance and having proper care, and the fact that a lot of this is poverty driven. There's real problems in the sense that if there's no other opportunities, then it's not a bad choice if it's the only choice. I grew up in a very, very poverty-stricken area as well, and I grew up in a rural area, but that doesn't mean that it didn't have a lot of drug problems. As a matter of fact, there were tons of drug problems because it's in the woods and no one knows that you're there. And there were people who chose to deal drugs because there were no other jobs. So I think the other thing too is that these are not like, you can't isolate this out and be like, this is a problem over here. It's always intrinsic and completely tied to other things. And I wondered if you had anything to add about that.
For sure. Poverty and substance misuse go hand in hand, but I have taken care of just as many rich people, people who are affluent, people with jobs who misuse opiates. I think a lot of this kind of stems back to how we've managed pain as physicians for many, many years. Mm-hmm. And I remember being a junior resident, again, 17 years ago, and being taught by my chief, you know what, you want to give 40 Percocet to that patient with the toothache because you don't want him to come back next week on your shift. Thinking, wow, well, that's wisdom right there. Here you go. Here's your prescription. And we were told that, after the decade of pain in the 90s, you've got to aggressively manage people's pain because if you don't do it, if you don't give them enough pain medication, you are mistreating them and you're going to give them chronic pain issues in the future. And don't worry about that addiction thing. That's not really a thing. And I remember having long conversations about this as a junior resident. So I think getting back to your original question, it's not just poverty, but it's, how we've managed pain historically. And, if you've got the right brain chemistry and you get exposed, you're at risk of opiate addiction. And it doesn't matter how rich or white or powerful, if you're a CEO or if you're a guy who lives underneath the overpass, you're potentially put at risk for that.
I think that's a really great point that you brought up, the correlation between poverty and addiction, because I think therein in that lies stigma, that we assume that people who are poor or homeless are addicted and that's why. You may choose to access money by dealing drugs. You don't choose addiction. And I think that's where stigma really lies, and that's where we start. We have to start with understanding that addiction to whatever it may be, alcohol, drugs, etc., is not a choice, it's a disease. And oftentimes it's hereditary. So you may not know, you may know it runs in your family, or you may not know, or you may not talk about it. But oftentimes what we see, and I don't know the specific correlation between addiction and poverty and other social or emotional issues, but what we do know is that you may have access to prescription painkillers and end up having a predisposition to addiction, and then that can be the catalyst for your addiction to prescription drugs, and which then may turn into heroin or fentanyl or carfentanil. And what we know is with addiction, the symptoms of the disease may look like behaviors that you may end up losing your job. You may end up losing your driver's license, which can really impair your income, and that may lead you to being in a state of poverty. But I think that's the conversation we're not having.
Yeah. Well, I'd like to open. I'm going to take one of these mics. I'd like to open this up to the group, and this is for. Oh, there's an extra one. Oh, never mind. You can have your mic. It's okay. I'll take this one. I want to open this up for questions to the panelists, questions to me, but also just conversation and comments.
It seems that depression, bipolar, manic, is also hereditary. Mm-hmm. And I'm curious if there's any kind of chemical correlation between people who have manifestations of depression, some quite serious, they're born with a chemical imbalance, mm-hmm. essentially, to the chances, the potential to become addicted to these more serious drugs. Mm-hmm.
There's definitely a correlation between mental health and substance abuse, without a doubt. We call them dual diagnosis patients. And it's hard to parse out oftentimes what happened first, the addiction or the mental health disorder. I find that a lot of people try to treat or self-medicate mm-hmm. with alcohol, with drugs, to try and help their depression. Anxiety in particular is a big deal that people self-medicate with. So without a doubt, there's a correlation between the two.
It's also really important to keep in mind that there is a lot of evidence for some mental health or mental illnesses, especially really pervasive or serious mental illness like bipolar disorder, schizophrenia, that have evidence of hereditary genes passed through family lines. However, to that, when you talk about depression or anxiety, personal experience and trauma is really important to consider. And when when we talk to individuals and we talk to families, that's another piece that kind of goes missing, is that we're so quick to solve, but we forget that individuals may have experienced trauma. Mm-hmm. And so the importance of trauma-informed care, whether it's trauma-informed medicine, trauma-informed policing, is really important when working with individuals, so you don't trigger more trauma, and that you can ensure that you're really listening and understanding what the need is, and if it is mental health and substance abuse, that those resources are able to be delivered.
I think it's also important to remember that there's environmental trauma. Cleveland so historically, there's areas of Cleveland that are geographically poverty-stricken, and they have been for over a century. I'm studying a case in 1908, and this area that these people lived in, where they were getting the lead poisoning and they were having these environmental traumas, is still an area in Cleveland that is still poverty-stricken. So it's a really important thing to note that sometimes you simply are surrounded. The trauma might not be like someone beat you, but you are literally living in and absorbing trauma from your environment, either chemically or just psychologically, and I think that's really important too. Other questions, comments? Mm-hmm.
I have a question. I used to work at a school. I got a question for the school kids. I used to work at a K to 8th grade. I'm retired now. But how is it being dealt with as far as education? I can remember some teachers, are they really going to the schools and informing not just the kids and the teachers, but the parents? Like with this panel now, it's like, wow, how many people don't know about this, or even the kids? How to educate them? Is there anything going on that's more in the schools?
We just happen to have some students here. Hi guys, they come to all my events. It's Old Home Week.
Well, we go to a kind of unique school in that, a very unique school in that health is a big focus. Like, we have real sex ed. Which is really surprising. But even there's a small part of our health course is on substance abuse, but it's really not very much. And this is all new, practically. I didn't know that heroin wasn't from poppies. Like, it's definitely not a cohesive education that we're getting. You got anything?
Oh, sure. Okay. So our school is, I would say, like, upper class. Like, I know a lot of people there are on like financial aid and stuff, but for the most part, it's in an area where people like have money and stuff. And so it's not something that I don't think I've ever been talked to about with staff or anything, but I used to go to, when I was in K through 8, I went to a very large school with a lot of lower class people, and there it was like brought up, but we were younger, so it wasn't something that was like very like installed in us, but it was brought up of there was like a slogan that I don't remember. I know like I still have a shirt from being in middle school that says like, yeah, there was DARE, and then I still have a shirt from middle school that says like, don't be a dope, just say nope. And like, so I still have that. So like, that's a thing that happens like when we're younger, but also we were like a lot younger then. I think it's more important like for people our age because we're almost like legal adults, but then I was only like 9, so.
So systematically, it's still not happening. Other questions for comments to the panel, to each other, to me? Yep.
I do have a question. Knowing that anxiety is prevalent in all schools today, the kids really suffer from anxiety, how are we to address that to try to prevent them from using alternative methods to deal with their anxiety?
It's a great question. I wish we had a teacher here, but would you guys like to?
Actually, I have an answer for that. In Rocky River, where we live, there's a very high push to test these kids frequently. And so they're trying to sort of address that by training parents and children in mindfulness. And I think that's really the antidote, is metacognition, thinking about what are you thinking? How do you feel when somebody says something to you? How do you feel when there's a test coming up? How do you organize yourself to get ready for the tests and the stressful situations in your life? And I think that's really the key, and none of us are really talking about that in medicine, but really mindfulness and cognitive behavioral therapy kind of go hand in hand, and that's absolutely critical in getting people to function in society without a lot of stress so that they're not anxious and that they're prepared for their day. It works for me. Whenever I have a code coming in, the first thing I do is I check my own pulse. It's, again, one of those brilliant things my chief resident taught me back in 2000. And also reminded me the patient is the one with the problem, not you. So you take a nice deep cleansing breath, clear your mind, and get ready to care for whoever or whatever comes in the door. It's very helpful.
I think we often forget that we all have physical health, but we all have mental health, and they're connected. But a lot of times, especially in our culture, we want to disconnect them for some reason, and we want to stigmatize the mental health. We all experience anxiety at some point in our lives. We all experience depression sometimes in our lives. It's when it becomes pervasive and it impacts our daily living. And I think when we think about kids and school-age kids, especially in schools, health is mandatory in all schools, but it's not a full year-long course. There's a variety of mandates by the state that you have to accomplish, and so there's a lot to cram in a very small amount of time, whereas this is obviously very complex, and it takes a lot more talking. And not only do you have to talk about understanding awareness of mental health and substance misuse, but you have to learn how to prevent it and how to intervene when you see your friends either talking about something or about to use. And that takes time, and it takes teacher power, and and that can get, when you're thinking about our current education system with testing and different things, it can become complicated. But I think it comes from, it's a trickle-down kind of effect. And the placing importance on social emotional learning is huge, and that awareness, and again, breaking that stigma down that it can be addressed, and that there's a lot of coping skills that can be learned to cope with the anxiety or whatever other feelings you're feeling.
We have an incredibly stressful, the social stress of what we experience in society, I think, has always been great, but we have such access issues now in terms of this Facebook and Twitter, and there's a whole other self to manage for young people that there didn't used to be. Like I didn't have Facebook. Like my wall was actually just my wall, my bedroom wall. If I put something there, no one saw that, just me. But there's a sense in which I think we're asking people to much more quickly manage a public self and all of the anxiety that goes with that. And we don't talk about that. It's very, very rare that we talk about that. I was a college professor for many years, and that was usually when the first, like, we would have conversations about it at freshman orientation, and the students had never heard this conversation before, and they're like 19. So I think that's a really good point. Okay. I'm looking here, and I'll come back.
My question really, we started this talk about with the medical industry and how we've gotten there. And my question really drives back to big pharm and where they are today in prescribing these medications that actually become the gateway to daily use on the street or wherever else they're getting it from. What do we see in the short-term solution for that, and what do we see on the long-term solution for big pharm prescribing medications?
It's a good question.
Well, I can tell you that the governor has given us very, very stringent guidelines that we're obligated to follow. As the Cleveland Clinic, we have also modified our set orders to reflect very brief courses of treatment, 3 days only from the emergency department, the lowest quantity of medication in the lowest concentration to get the job done. We also tell people no. In the past, we were really driven by patient experience scores where we were told, make them happy, do what you got to do and make them happy. And many people interpreted that as, you know, instead of just having a conversation and explaining and spending the time, just writing prescriptions. And we don't do that anymore. We say no. And we say, listen, you know, I care too much about you. I don't want to do anything that's going to harm you. And I have to follow the guidelines and the state law. And unfortunately, I can't refill your long-acting narcotics. I can't give anything that's extended release. I can't give you an opiate patch. I can maybe give you a handful of pills, but only for an acute purpose and only for 3 days. And I think that really makes a big difference. People don't have as many leftovers. Same thing for my surgical colleagues. They're giving much less medication at the time of operations and checking in with people, you know, within a couple of days. Hey, how are you doing? Vast majority of people aren't looking for refills. So that takes a lot of pills that otherwise would be in circulation and on the street, potentially to be stolen or diverted or misused. Those are no longer circulating around.
I can't speak specifically to big pharma, clearly little social workers, so can't speak to that. But I do know that there's a lot happening in various states, and I know our Attorney General is looking to start lawsuits against some of these large pharmaceutical companies. In Cuyahoga County, we have a really dedicated opiate task force that's been in existence for almost 10 years now. And what's coming out of that is a collective force to really address the demand rather than the supply. So what you're seeing now is if you're you're getting a first-time prescription from Drug Mart or Mark's Pharmacy, you'll be receiving a pamphlet that will describe what the drug you're receiving, that it's an opiate or an opioid, and that there are risk factors, and to know, do you have addiction and runs in your family, and this is what, the good and the bad of it. There's also been a surge of increased awareness about drug drop-offs. So in the city of Lakewood, right downstairs in our police department, there is a prescription drop box that you can just anonymously drop prescription drugs in that you don't want to keep at home. They're in pretty much every police or fire station around Ohio that you can look up easily online. So there are ways, and then offering programs, having community conversations, and increasing financial and community support for recovery. And recovery looks like a lot of different things, but ensuring that we're looking at supporting individuals who are struggling with addiction so that we can decrease the demand for the supply.
I want to add something here because one of the other problems is still money. So you're right. On one hand, it's increasing the supply of money to treatment programs, but there's still reward rather than cost to pharmaceutical companies for creating and for distributing. So one of the problems that we still run into is that we have an economy that, you have to face it, the United States economy is very much a medical economy. This is why we still think of, when I ask my high school kids who come into the museum what kind of careers do they want, and they all say doctors, and I ask them why, they're like, because I'll make money. There's a sense in which we're still kind of pushing this idea that that is where money is to be made. So, you know, I have a question really to all of you, and that is, in a situation like this, is it always just about, it isn't always just about putting money into recovery, it's also about the laws and the legal systems that are creating barriers so that it's actually no longer attractive to continue to push and prescribe. And I think that that's a big part of this. It has to be legislative as well as, you have to have help on both sides. You can't just be pushing recovery, you also have to be limiting the demand for these kinds of prescriptions. So I think it's a give and take.
I actually am at the Cleveland Clinic, and I work in chronic pain management. So we see a lot of people who come in with opioid addiction, you know, from the chronic pain issue that they have. One of the things that we do, especially because I work primarily in the hospital, is when we send someone out with, say they've been there for, we have some patients there for a week, we have some patients there for 30 days, some of them are there for 365 days. What we have to do then is to provide them with a reasonable taper so that there's no withdrawal symptoms, because what are they going to do if they start withdrawing? They're going to go look for other sources in order to like kind of prevent those withdrawal symptoms, so they kind of self-medicate in that regard. So one of the things that we have to do is make sure that we are responsible and that we are giving them a reasonable tapering regimen that would allow them to taper smoothly off of the opioid while managing their pain in a like acute post-op or whatever it is that they came in for, an acute on chronic issue. So one of the things that I find is lacking in medicine in general is just the knowledge of knowing that you can't just give a patient, here are 40 tablets. Okay, great, and you've put on your script Q 6 hours or every 6 hours. Well, then they're just going to keep taking that until the prescription's done, and then they're like, wait a minute, I was taking this 4 times a day. Now what? I just finished my prescription and I have nothing left. So oftentimes what is missing, this is the piece that is missing, is a tapering to nil, to nothing. So you go from every 6 hours for a few days to every 8 hours for a few days to every 12 to every 24, and then you stop. And this is something that is so huge that we're missing out on in general. And I think, yes, it shouldn't be the patient's responsibility to know that, because they don't know that once they stop it, they're going to have withdrawal symptoms.
Right.
So opioids are tricky, and they're there for a reason, and for an acute process, it's definitely a reasonable thing, but for chronic pain, it's not something that we generally use. But tapering regimen is always the key. So I think that would prevent a lot of the issues that we have, I think.
Cool, thank you. Thank you. I saw a bunch of hands on that last round, so all right, I'm going to get you, and I'm going to do you, and I'm going to go over there. Okay.
The last time I heard, Lakewood had the highest amount of fentanyl deaths in Cuyahoga County. Is that true? Is it still true?
Lake County now?
Well, my question is, do we keep a database here in Lakewood of the people that overdose and or die?
Yes. So how the numbers and keeping track of numbers of overdoses and deaths to overdoses in our county is tricky, because it also depends on the individual community's ability and how they track data. So Lakewood has state-of-the-art data collection. So they're able, when somebody has overdosed or has died from an overdose in Lakewood, police and fire are responding, and that information's being collected so that we're able to keep accurate track of numbers. Whereas
Just numbers. You don't have any socioeconomic data in that database, do you?
Well, that's protected.
Yeah, so patient protected.
Right. Anytime fire EMS is responding, that's all HIPAA protected, so confidentiality.
We do track that through the clinic, and also the medical examiner does as well. The problem is that the toxicology testing and the attribution of the cause of death can be very challenging to obtain. Sometimes toxicology testing can take up to 6 months to be complete, depending on the suspected cause of death. And so these data lag significantly behind. We're just getting 2016 data right now that we can base any kind of information off of. So that's the thing. Until somebody who dies today, we'll be talking about it in about a year.
All right, and you had a question here.
This actually is kind of back to the whole issue of starting with pain and what we tolerate and what we don't. In 1982, when I had my first child, natural childbirth had come back. And so my mother, who was knocked out and had a baby, we decided maybe that wasn't so good. Maybe we needed to actually feel the experience. And so, I had 3 kids with no drugs. And I felt the experience. But it was acute, and there was a great bonus at the end. Do you think that we will ever get to the point culturally that we will acknowledge that sometimes we have pain, we manage, we take off those peaks, and I'm not talking about people who are suffering with cancer or something that is to a different end. But will we ever actually have those conversations, that pain, I now see young parents who recognize that a fever is not something you always immediately disappear for a child. It gives you information. Will we use pain like that ever again?
People are going to think that you're a plant in here for me. I love that question because I think that it says so much about us culturally. So secret, I was the managing editor of Culture of Medicine and Psychiatry for 10 years. So I saw lots and lots and lots of medical anthropology reports from other cultures. And it's really fascinating. We are by far the most pharma-driven culture in terms of dealing with pain. Lots of other cultures it's forms of hypnosis, there's therapies that have to do with, sometimes they look religious, sometimes they are, sometimes they're not, social structures that are in place to help manage and support pain. It's a very good question. Will we go back? One of the interesting points that I did not say during the early part of the talk, but is true about early anesthesia, is at first they killed more surgery patients. Because one of the ways they knew if they were cutting too deep had to do with the patient's response. And so back to this idea about delivering babies when the mother's knocked out, you don't always know what's happening to that patient because you can't feel their pain and neither can they. And so, even in early surgery, at first people thought, maybe, I told you that he felt it was a breakthrough, anesthesia was a breakthrough, but there was a period of time when it seemed like it was actually going to cause many, many more deaths because doctors were cutting deeper and having surgery much longer. They weren't doing it in 2 minutes. They were plucking around in there because they could. And so I think it's always good to ask what we're trying to manage, why we're trying to manage it, for how long we want to manage it. I think those are really excellent cultural questions and personal questions that we should ask. And I don't have answers to them, but I think they're good questions. Did you guys have some response to that?
Yeah. We live in the culture of the quick fix. Nobody wants to take time to heal their back pain by going to physical therapy and doing exercise and meditation and yoga. And I say these things and many people roll their eyes at me and can't believe that I'm saying something so stupid when I could just give them a pill. And I think I think the needle is kind of moving back in that direction. And every so often somebody doesn't look at me like I'm crazy when I tell them to manage their stress with mindfulness instead of giving them Xanax. Or, physical therapy and yoga really can be very, very helpful for your chronic low back pain. So hopefully we'll kind of go back in that direction and away from the Burger King, here's your pill, here's your fast food, here's your rapid cure-all. Because unfortunately, there's no cure-all for aging. There's no cure-all for arthritis. I'm pretty good at what I do, but that's just not something I can make any better.
I think that the cultural shift is going to be slow moving, but I am hopeful. There are when we're looking at innovation when it comes to how to address and face addiction, I know out of New Jersey, there's an emergency room that's starting to prescribe just that. They're saying you're coming in with pain, you're coming with anxiety. They're not giving you Xanax or whatever it might be. They're giving you, you should try 6 weeks of yoga or Reiki or different types of alternative medicine that can address the situation at hand. Obviously, if someone's coming in with an acute pain issue or medical issue, that's not what they're giving, but they're starting to look at it differently. And although that's innovative and different and not mainstream, there's starting to be a glimmer of thinking outside the box.
Western medicine has a tendency to think that it's right a lot. And in Cambodia, they often think that illness is caused by, I think it's called the Kayol winds. It's this idea that illness is caused by imbalances, which is true, actually. Not necessarily by winds, but by imbalances. And they use cupping and coining. And we all know what cupping is now because of the Olympics. But coining is where they take a coin and they rub it quickly on your skin. It brings red lines to the surface. And to them, this is how you manage pain and disease. And I gave this talk at Grand Rounds once at the University Hospitals. And someone asked me, they said, well, but it doesn't work. And I said, have you asked a Cambodian? Because really, this is a personal question. And if it's working for you, then it's working for you. And that doesn't necessarily mean that it's going to work for every single individual. I get really bored during yoga. So I have trouble with that one. But there's lots of other things. I do weightlifting. I do all sorts of things and boxing. And fencing a little bit. Violent sports, I don't know. But there's other ways that you can address your own mindfulness issues. Any comments on that? Because I do think it's a really interesting point about pain.
So I suffer from chronic migraines too. It's a genetic thing in my family. And I can't take pain meds. They just make me super sick for some reason. And even like anti-nausea medication just doesn't work. So usually I just deal with it. But my sister is now a certified Reiki master. And it's gotten to the point that the only thing that helps me is Reiki, or I know like people who like consider themselves healers, and whether it's like a pseudo effect or not, it works for me, so I do it. Like I don't have any pharmaceutical medication in me. It just doesn't work, and when I do take it, it makes me sick. So that's how I deal with my pain.
Yeah, perfect, great. My thoughts?
So a lot with pain is subjective, and it is the perception of the pain. And so if a patient comes in insistent, adamant that whatever medication you're going to give them, if it's not the opioid or if it's not whatever they traditionally take, like their IV Dilaudid or whatnot, their pain will not be controlled. So they fail to they just completely disregard any other alternative medical therapy that we might have for them. So it is oftentimes mind over matter, because they can block whatever efficacy that they might get with a different drug, just because they're saying, no, my pain will still be the same no matter what you give me, and I can only have my pain managed with this particular medication. So a lot of this, I mean, if you set your mind to it, and it goes back to mindfulness, and just, you know, it's training these patients to like think outside of the box, you know, figuring out what is the thing, the magic bullet for them, because it is very, very subjective, and pain is different for me than it is for you, than it is for you. So trying to find what is that magic bullet for that individual, and it's really getting to know a person before you can actually manage their pain. So that's why in chronic pain management, you get a really long time to get to know somebody, and you try to figure out how are we best going to manage your pain. Acute pain is a totally different animal altogether, but it's the chronic pain that actually is, you know, it's mindfulness and
ketamine infusions.
Oh, we do that a
0.3
lot.
per kilo ketamine.
We do
I've
that a
had
lot.
lots of people tell me I can only get better with IV Dilaudid. I'm like, here, let me try something else. Totally different medication we use. It's a former anesthesia drug. Outstanding. I've had many. It's not a narcotic. We do the infusion right in the emergency department. We get them better. About an hour later, they go home high-fiving me. I've never had anybody have a bad outcome with it. Stuff's really great.
The other thing that is true is that we are somatic as well as psychological creatures. And if you are in a bad way, you don't have support, you're going through a divorce, you're had a parent just die, you will feel pain in a lot of ways, and you'll feel pain differently than you will if you are highly supported. And so I want to get back to the idea of the support system that you yourself went through and the support system that you offer, and I want to talk to you about that a little bit. How does support alleviate pain?
You know, I have a woman who's very important in my life, and she says, you get as many people as you can on Team Gina, because it's going to make the rest of your life a lot easier. And I'm going to like tie this into literally everything that we've talked about. I started seeing a therapist. I've been in recovery for over 4 years, and I started seeing a therapist in the last few months. And I've been diagnosed with anxiety that I was treating myself for many, many years. And I was also self-medicating because I have chronic shoulder pain. And it's really funny that, you know, my chronic shoulder pain is exacerbated when I get anxious, and when I get stressed out. And so, you know, getting my therapist on Team Gina and teaching me that mindfulness, the rewards have been exponential, you know, because I had that support. I actually went to see her initially for a loss that wasn't dealt with. The loss happened in my recovery, and it was just time and time again, and it just wasn't being dealt with. And so I went to see her, and, you know, lo and behold, I went to see her for something, and she helps me with something else. And, you know, because she helped me, I get to help other people. I lost my brother before I got sober, and, you know, there was a series of events and whatever. And, you know, I work for the Woodrow Project, and one of the women at the house there just lost her brother. And the series of events in which she lost her brother were identical to the series of events in which I lost my brother. And it was really incredible being able to help her and give her my mother's phone number to give to her mom. And, you know, maybe I wouldn't have been able to help her so much if I wouldn't have, you know, spoken with my woman who helped me so much. And it's just all intertwined, you know, and the reason that I'm even sober in the first place was because I had access to treatment. I don't know, I feel like I'm rambling here, but it really is, it's all connected and it's all supportive. And you know, my entire recovery is, has been absent. Stigma has been absent from my entire recovery. People have been there every step of the way to support me, and they have had nothing to say about, you know, anything. They've just said, we're glad you're sober. Unfortunately, that's not the case for everybody. You know, I was afforded world-class treatment, you know, and I was able to very easily get into a women's recovery housing because my parents had the financial, you know, ability to pay for me to go there, and that's not the case with everybody. You know, and so I don't know, just being able to have a comprehensive system for everybody. I'm really rambling here, but oh, okay, terminal uniqueness. You guys love that. So terminal uniqueness is something that's used a lot in the recovery community, and it's pretty much, you cannot help me because you don't know what I'm going through because I'm terminally unique, and the terminal comes from you can't help me, so I'm going to die. But I guess I use it to describe why peer support is so important. And, you know, being able to go and get into treatment and, you know, have professionals help me and, you know, have a social worker and have a counselor is amazing. But I'm never going to get there if I don't think I can. And so to have somebody stand by your side and say, hey, listen, you can do this. I've been where you are, and hold your hand through the process. It doesn't take away from the counselor or the social worker. You know, it does not cover up, and it does not, you know, double up on what they do. It gets you there. I dated a guy before I got sober, and he him and I did the same thing. We did the same things and we were on the same path. And about a year before I got sober, he told me that he was sober. And, he told me how he did it and what he was doing now. And I didn't know it at the time, and neither did he, but that was peer support. And because he told me these things, I knew what to do, when I actually realized that I had a problem and I needed to do something about it. I knew what to do because he was there and he gave me peer support.
And I think that when we think about pain relief, structures, systems, support is pain relief. It is pain relief. There's nothing more painful than suffering by yourself. And I think that as we think about recovery, as we think about crises, as we focus on moving forward as a community, as a city, as a region, one of the biggest things is going to remember that you need support to do that, and not everybody has it available to them in the same ways.
So that's a great point. And all of us who are sitting up here happen to be a part of Project SOAR, which you've heard about quite a bit this evening, which is a pilot program, and it's a true collaboration between the City of Lakewood, especially our police, fire, and human services, and through our mayor and city council leadership, the Cleveland Clinic Emergency Department here in Lakewood, the Adams Board of Cuyahoga County, so the Alcohol, Drug, and Mental Health Addiction Board, and then the Woodrow Project. And there is a handout up on the table that you can take with you that kind of describes it. But this pilot program is centered around peer support. It's the core. It's Gina and Woodrow Project's peer supporters who are trained to utilize their story, their personal story of recovery, and the skills that they've built to support other people. And Project SOAR is a rapid response to overdoses, specifically through the access point of the emergency room, follow-up home visits to individuals who live in Lakewood to help them access treatment and recovery supports. It will be a safe station at our fire station where anyone can drop in at any time to access peer support. We haven't launched yet. We're hoping to launch hopefully in the next few weeks. But this kind of model has to be in a community. It can't be owned by a city, it can't be owned by a hospital, it can't be owned by a nonprofit. It has to be collaborative, it has to be comprehensive, because we all have strengths and gaps, and when we come together, we fill those holes. And what's really unique about Project SOAR is that the core of what's going to be happening is that peer support model. But it's also this. It's these consistent community conversations. It's talking and breaking down stigma. You're not going to see dark images of children hiding in corners and people in pill bottles in the middle of our town square. We're using images that are reducing stigma. They're not going to be fear-based, because if we're producing fear through our imagery, even the colors we use and the words we use, we're just producing more stigma, and we're not getting anywhere. And we're really looking to families. Gina and her family are incredible people and have given so much to this city. Just being able to have families support each other and navigate resources and deal with grief and loss. It's all about support. No one in a 5 by 5 mile square radius of a town like Lakewood should feel alone. And when we keep building walls of stigma, we're isolating individuals. So again, these kinds of efforts are breaking all those walls down so we can start facing addiction together and facing it in a true way.
I think so we'll end on that as we've gone a little bit over time. But what I would like to say to all of you, and first of all, thank you very much for allowing me to have one of the conversation events as part of the Lakewood City event and connected to SOAR, is that the solution to almost anything. I'm working in medical history. I can say this because I've studied my books, but is right here in this room. It's other people. Community conversations, not just over problems like opiate addiction, but it's definitely a big one, but over other problems of access, of support. It is about you. That's why I like having you talk to us rather than me just talking to you, even though, sometimes I'm entertaining. It's the conversation that matters, and I am deeply appreciative for all of you being here as part of this conversation. Please don't stop having conversations about key issues in our community, about key issues in health. And finally, let me invite you to come down and see the District Museum, because we do have quite a large collection there talking about public health and community and ethics and outreach. And you are all welcome. We're also free, which is handy. Thank you again so much to all of you and to our panelists. Thank you.